Tuberculosis is the disease that is caused by the Mycobacterium tuberculosis. It's actually a bacteria. So in this video, we are going to deal with the first line drugs for the treatment of tuberculosis. So we have 4 drugs. First, Isoniazid. Second is Rifampin. Third is Ethambutol. And fourth one is Pyrazinamide. In this video, we are going to deal with the main focus is on the mechanism of action of these drugs. But we will also cover the mechanism of resistance, a little bit touch of pharmacokinetics as well as the toxicity. So let's start with Isoniazid. So Isoniazid is actually a prodrug. It's given in inactive form, and in the bacterium it is converted in the active form. Next, it is structural congener of pyridoxine, and its main mechanism is that it inhibits the synthesis of mycolic acid. This star here, it indicates one of its clinical use, that is, it is used as a prophylactic agent in persons who are in close contact with the one who is diagnosed with tuberculosis. So let's deal with the mechanism in detail. So we have our inactive isoniazid that is converted into active form, and the active form actually inhibits enoyl ACP reductase. Here ACP stands for acyl carrier protein. This enzyme is actually an enzyme that is involved in the fatty acid synthesis, and so we can guess that by inhibition of this enzyme, our mycolic acid, that is main component of the cell wall, is not going to be synthesized. So isoniazid prodrug, it is activated by the product from this CAT G gene. This encodes a protein that is catalase peroxidase, and this actually converts isoniazid into active isonicotinoid radicals. These are active radicals, and they combine with NAD positive, NADPH positive, and forms a complex. And the complex that is formed, it inhibits the product of INHA gene, that is enoyl ACP reductase, the enzyme that is involved in the synthesis of fatty acids. So the overall effect of this drug is that it blocks the mycolic acid synthesis. Mycolic acid, mostly they have carbon numbers from C78 to C90, and they are responsible for the acid fast staining of the Mycobacterium tuberculosis. So the resistance actually occurs most commonly by the mutations in the gene that codes for the catalase peroxidase. So here, most commonly we have mutations in CAT G genes, but less commonly we have also mutation in this gene, that is INHA gene, that codes for the enoyl ACP reductase. So let's deal with the kinetics. So this drug, that is our isoniazid, it is metabolized in the liver by acetylation, and on this basis we have slow acetylators. Some people are slow acetylators, whereas other they are fast acetylators, and this acetylation ability that determines the half-life of the drug. Now let's move towards the toxicity of the drug. It's neurotoxic. That means it causes restlessness, seizures, etc., the neurological problems. Hepatotoxic, that means it is going to cause hepatitis, derangement in LFTs, etc., hemolysis, and rarely lupus-like syndrome. So the neurotoxic symptoms, they can be reduced by the administration of pyridoxine. Next drug, that is our Rifampin. It's actually a semi-synthetic antibiotic belonging to Rifampin group. We will discuss a few more drugs from this group, but this is the main drug, and I want to tell you in the introduction about the clinical uses other than in the treatment of Mycobacterium tuberculosis. This drug is also given in leprosy and in the meningococcal meningitis, and also to treat certain staphylococcal infection. So now let's deal with the mechanism of action in detail. So it actually inhibits the bacterial DNA-dependent RNA polymerase. This RNAP causes the transcription of bacterial DNA into messenger RNA. Okay, so this enzyme is made up of various subunits. This drug actually inhibits the beta subunit. It actually binds with the beta subunit, and this enzyme is different from human RNA polymerase, and that is responsible for the selective toxicity of this drug in the bacteria, not in the human. So let's deal with this in detail. So our the RNA polymerase of the bacteria it binds to the DNA of the bacteria and initiate transcription at the promoter site. Okay, so this drug is going to bind to the beta subunit on a pocket on beta subunit of the same enzyme, and this pocket is actually near to the site where transcription is actually occurring, and 2 to 3 nucleotides are inserted, and then this drug that is bind near to the transcription site, it actually blocks the further transcription. So we can say that transcription occurs but elongation does not occur. Transcription is initiated but only 2 to 3 nucleotides have been inserted, and then the further elongation of that chain of mRNA does not occur. So we have no formation of messenger RNA, and as a result there is no formation of protein. So we have our inhibition of essential metabolic process, and this drug is bactericidal. So the resistance actually occurs by the mutations in RPO gene, and this gene encodes this enzyme that is DNA dependent RNA polymerase, RNAP. So now let's move towards the other 2 drugs as well as the toxicity that is caused by rifampin. This drug undergoes enterohepatic cycling, as well as both the free drug and the metabolites. They are orange in color and they are eliminated by the feces. If I talk about the toxicity, then drug interactions they occur, and that's a very important point. And the other rash, thrombocytopenia, and another from the hematology, like we have anemia, nephritis related to kidneys, liver dysfunction, and flu-like syndrome. These are toxic effects of this drug. So other members of rifamycin groups are rifabutin, and it is preferred in AIDS patient. Rifampin, it is given once weekly in a once in a weekly dose. Next is our rifaximin, and this is given in traveler's diarrhea. Next drug, that is ethambutol, and the mechanism of action is a little bit different. So our mycobacterial cell wall actually consists of arabinogalactane that are linked to mycolic acid. We have discussed that our first drug, that is isoniazid, that deals with the inhibition with the formation of these fatty acids. But here ethambutol actually deals with here at this point. So it inhibits an enzyme that is arabinosyl transferase. So this enzyme, it is encoded by the EMBA gene and EMBB genes. So arabinosyl transferases, they actually polymerize arabinose into arabinogalactane. Okay, so when this is inhibited, we don't have this product. Okay, so that when we have no arabinogalactane, our mycobacterium, the mycolic acids are not linked to peptidoglycan layer. So this is actually a bacteriostatic drug, and it is given orally and excreted in the urine. Toxicity, visual disturbances are very important, and here this drug causes retinitis as well as decrease in visual acuity and red-green color blindness. Whereas peripheral neuritis and hyperuricemia, they are also important. Confusion and headache may occur, but that's not an important point to remember. Next is our pyrazinamide. This is actually a product, pyrazinamide, and it is converted into pyrazinoic acid. So pyrazinamide is converted into pyrazinoic acid with the help of these enzymes that are pyrazinamidases, and these are encoded by PNCA gene. This product is going to act on many substrates. So it's going to inhibit FAS1, and that is fatty acid synthase. So there will be interference in the mycolic acid synthesis as well as decrease in the synthesis of CoA, that is going to impair the metabolism. We have the inhibition of translation, and protonated POA re-enters the cell and acidifies the cytoplasm, and these are the effects. So we have toxicity, that is PP, porphyria, photosensitivity, triple M, myalgia, maculopapular rash, and malaise, hyperuricemia, hepatotoxicity, arthralgia, and gastrointestinal upset. So that's all about the first line agents. If you like this video, click on the like button, and also thanks for watching this video.